Hello and welcome to the Retina Radar podcast. I'm Arshad Khanani, Managing Partner and Director of Clinical Research and Director of Fellowship at Sierra Eye Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. In each episode, I'll be sharing information on the latest breakthroughs, clinical insights, and practical pearls for your everyday use. We'll hear from leading experts, explore cutting-edge research, and discuss the trends shaping our field. Whether you're in clinic, in surgery, or on the move, Retina Radar keeps you informed, inspired, and ahead of the curve. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Before we begin, please review the faculty disclosures and learning objectives. If you have a question for our experts, send it to us at cme@vindicocme.com, and it may be featured in a future episode. This podcast is supported by an educational grant from 4D Molecular Therapeutics, AbbVie, Adverum Biotechnologies, Alkeus Pharmaceuticals, Astellas, EyePoint Pharmaceuticals, Genentech, a member of the Roche Group, Neurotech Pharmaceuticals, Ocular Therapeutix, Oculis, Regeneron Pharmaceuticals, and REGENXBIO. Today, I'm joined by my good friends and colleagues, Drs. Judy Kim and Barry Kuppermann. Dr. Kim is a Gene and Tom Walter Distinguished Chair of Ophthalmology, Vice Chair of Education, and Medical Director of Clinical Research at the University of Texas Southwestern Medical Center in Dallas. And Dr. Barry Kuppermann is the Director of Gavin Herbert Eye Institute and Chair of the Department of Ophthalmology at the University of California in Irvine. Welcome, Judy and Barry.
Thank you. Arsha, you're a proud grad of UT Southwestern, so we're so proud of you.
Oh, thank you so much. UT Southwestern is so lucky to have you, Judy, and you've done so many great things since you joined them over the last year or so. So both of you are legends in our field. I remember being in training and listening to your talks on the podium and learning from you how eloquent you are, how much data you know, and how kind both of you are to trainees and to fellows and residents, and even me, mentoring me. So I'm very, very honored to have both of you here. And this is a special podcast. Usually we have one faculty. Today we have two legends in the field. So the audience will have the double take of Barry Kuppermann and Judy Kim today, and I'm sure they'll enjoy this podcast a lot. So we'll be talking about non-invasive treatments of DME and DR, and both of you have done so much over the last 2 decades in terms of moving the field forward. But this podcast, we ask you about your journey to retina and your favorite hobby before we dive into the topic. So Judy, I would love to learn, how did you end up in retina and what's your favorite hobby? And then we'll ask Barry the same question.
Well, thank you, Arshad. I'm honored to be here along with Dr. Barry Kuppermann, a longtime friend. I was trained during the height of the AIDS epidemic, my medical school at Hopkins. And during between second and third year, I was chosen to do Howard Hughes NIH Research Scholars Program. So I actually did a whole year of research at NIH. I was going to be an immunologist. I was going to conquer AIDS virus. But then when I came back, I took an elective, ophthalmology, thinking that it's a nice, easy one to ease into the big rotations, and I just fell in love. I'm a very visual person, and retina was just amazing. So it's got me sort of started thinking about retina at that time. But then when I did my residency at Bascom Palmer, I'm old enough that during that time there weren't that many women in retina. And married woman with a child in retina was even rarer. And I thought it was not possible to do retina, even though I wanted to do retina because of the call lifestyle, as you know. But it was my mentors at Bascom Palmer, such as Dr. Harry Flynn, Dr. Don Gass, and even Steve Fluchfelder, Dr. Fluchfelder, who is my cataract mentor. They all show me that I can do it. I can enjoy my surgery. The cerebral aspect of retina, the innovative aspect of retina, the research part of the retina. I'm a geek. I love research, so I gravitated towards retina, and I'm so glad I did. And I thank all my mentors, and no turning back. It was the best decision I've made, next to marrying my husband.
Great. That's a great story. And oh wow, you work with some legends in the field, and it's unbelievable how people can influence our journey into a field, and you work with the best in the field, Judy. So that's excellent. Barry, how about your journey?
Well, to retina, well, mine was sort of also complicated, but some overlap with Judy. I was very interesting to hear yours. I'm also pretty geeky. I got a PhD in neuroscience at Caltech. I had no interest in going into medicine, so I went to Berkeley, studied biophysics, then Caltech got a PhD in neuroscience. But the area of research I was doing, I was interested in synaptic plasticity, sort of how we learn through synaptic rewiring. And the system that we used as a model was the visual system. And so we used the sort of human weasel modeling of the ocular dominance columns, which ended up with the Nobel Prize. Not us, of course. Hubel and Weasel in Harvard got the Nobel Prize, of course. But that led me into vision. And then my research began to have clinical implications. So I thought, well, maybe I'll go to medical school. That'll be fun. And I actually went to Miami, to University of Miami, because at the time they had a program for people with a PhD to get an MD in 2 years. So I created my own 7-year MSTP program, 5 years at Caltech, and then 2 years at Miami. And so I certainly was, and then when I went to Miami, of course, I already went with the sort of preconceived notion of maybe ophthalmology. But again, being there at Bascom Palmer, I had a chance to interact with many of the people that Judy referenced. Then when I went to do my own, but then again, an overlap, Judy, with this was during the height of the AIDS epidemic as well. And when I came to USC Doheny, again, Doheny at the time was USC, now it's UCLA. That's still very confusing to many of us from back in the era. But under the tutelage of Steve Ryan, another legend, and Narsing Rao in particular, when I started my clinics, again, I didn't mention, but my family is from Brazil. I speak fluent Portuguese and Spanish. So they're at LA County Hospital. It's mostly a lot of Hispanic people. So I'm fluent in Spanish. I was enjoying speaking with them in Spanish, but a huge socioeconomic divide. But 1/2 day a week, I was suddenly taking care of all these guys with the exact same age, same mustache, and they were all going blind and dying from AIDS. And that was an epiphany for me. That's what galvanized me to go into retina and choose that as my career. And the first, decade or so of my career was dedicated to the ocular complications of AIDS. And so that was sort of my motivation, was following my heart, following my academic interest, intellectual interest.
Wow, what a great journey. But it seems like Judy and you both cross paths, and sometimes the younger retina specialists are so lucky, right? I mean, here you are struggling with ocular complications of HIV and AIDS, and there's not many treatment options in terms of controlling disease. And I think both of you probably saw the unmet needs and how we have addressed them over the last 20 or 30 years. But there remains more unmet needs, and we'll talk a little bit about those related to DME and DR. But before we go there, Judy, what's your hobby? What does Dr. Kim like to do outside work? I know you work a lot, so and so does Barry, but what is something that's fun that you like to do as a hobby?
Well, that's an interesting question. I've been singing since I was 9 with a choir or a chorus or a group of some sort. So I like to sing. I still sing at church on Sundays. And others include photography, again, visual. And I like to garden. Right now, we have lots of tomatoes and cucumbers going. And I like to travel. Do I do well in any of them? Not really, but those are my hobbies.
Great. I like to garden and travel too. At least we cross paths there. So Barry, let's go to yours before we move on.
Well, I share a love of travel. Again, my father was an academic, so we took sabbaticals growing up. So I've continued to travel largely with family, but now more with just me and my wife. But also we like to garden here. We've got a nice garden here in Newport Beach. And separately, starting in COVID, I'm one of those people that ruined golf courses all over America by taking up golf during COVID. I have a I have two sons. My younger son, 24-year-old, is an avid golfer. So he lives up in Santa Monica. He drives down to Newport Beach and we play golf every Sunday. So that's become a new hobby of mine that I enjoy. Another thing I do very poorly, which everybody does poorly, but enjoys nonetheless. To follow on your theme, Judy.
I live on a golf course, but I haven't golfed yet, but I will learn from you, Barry. Okay, let's go into the topic at hand, DME and DR. So Judy, starting with you, you are in Dallas now, and I remember in training, diabetics everywhere, complications of diabetic retinopathy everywhere, patients going blind, even with some of the available treatments. So in your mind, what are the unmet needs currently in that space, and how can we address them with non-invasive options?
Yes, you are right. Here in Dallas, I'm seeing diabetic eye disease left and right every single day, and very advanced forms of it too. So if anything that we can do to prevent that, we can do it. I think, even before we talk about management, we have to start earlier educating our patients about diabetes, diet. I have this mnemonic A, B, C, D, E, S. A for A1C, B for blood pressure, C for cholesterol, D for diet, E for exercise, S for no smoking. So I think we need to educate our patients and our other discipline colleagues to how to prevent diabetes in itself. And then early detection. I still think early detection is not being done well enough. And then when we do see patients with diabetes, currently the anti-VEGF is the top. That's the era right now, after the lasers that we have been doing in the past. I think, there's a treatment burden of needing to come often for these shots for a number of years in some cases. And the needle part, nobody likes the needles. I mean, I can give it, but I don't think I could receive them, month after month as well. So things that can reduce treatment burden, that makes the treatment more acceptable to our patients, not as onerous, that can last longer so that they don't have to do as much. And something that's non-invasive would be great.
That's a great overview, Judy. I agree with you. I think the screening part is important. And I know you're involved with a lot of use of AI to kind of diagnose diabetic retinopathy. And I know we have many FDA-approved algorithms. I'm just surprised that they've not been adopted as widely as all of us would have thought. What do you think is happening there? Why can't we adopt PCP getting photos, AI reads it, and then if they have diabetic retinopathy, they come to us? I feel like more and more patients get dropped between coming from PCP to their optometrist. What do you think?
Yes, recently I did a talk for the American Ophthalmological Society on AI, and I commented that the uptake of AI for diabetic retinopathy screening is only 0.01%. So it's very minuscule. Why? Could be the upfront cost. There's cost to the cameras. There's the business model that these companies have that might not be attractive to our primary care doctors or endocrinologists. Maybe they don't know about this. So we need to educate. We have to be the, proponents of some of these. Maybe the reimbursement is not big enough for some people. It pays more to see patients in person than do it through AI DR screening. So maybe some policy change is needed. So I think we're still working through this. And because of our payer system, fee-for-service, and multiple different systems, healthcare systems, we, United States, may be actually delayed in terms of AI screening compared to other smaller countries like Singapore, where it's universal screening, government run, and more health conscious and prevention conscious than us.
Wow, that's a really good overview. I was thinking maybe 2 to 5%, but it's 0.01%. 1%. That is crazy. Yeah, and thank you, Judy, for leading that. I know you are really vocal about policy changes so we can get diabetics, diagnosed early and hopefully improve their outcomes in terms of when it comes to vision loss. So Barry, you've been involved with a lot of developments over the last 2 decades. You were really, really close with the dexamethasone intravitreal program. You have been part of many of the anti-VEGFs that have come out. Now, tell us about this new modality, this non-invasive novel eye drop, OCSo1. You recently gave a talk about the program at Clinical Trials at the Summit in 2025 in June. So can you tell us the current evidence on OCSo1? How does it work? What data we have and what to expect in the near future from the program?
Sure. Thanks, Arshad. And again, I agree with Judy's comments. So much surprising how little uptake there is of the AI aspect. So I agree. There's in diabetes in particular, I think there's a lot of unmet needs, and I think we're going to talk about them. Certainly, again, that needle issue that Judy raised, having an eye drop. Now, the trouble is the eye is a formidable barrier to getting drops all the way to the back of the eye. It's not easy. But steroids have been able in certain, for example, CME and other conditions, we can have some efficacy, non-steroidals as well. What OCSo1 is a very potent form of dexamethasone. It's a product that's bound with cyclodextrin to have longer residence time on the surface of the eye, better penetrance. And so there is a whole program underway. And I presented the first 148 patients, and I can review that data briefly, of topical treatment of diabetic macular edema. Kind of amazing, but the sort of the real bottom line of the story is that there's now 2 fully enrolled phase 3 trials, each with 400 patients, each 1 year long. So over 800 patients enrolled, or about maybe exactly 800 patients enrolled. And we anticipate data coming out sometime next second quarter next year. I think the end date is around April. So who knows, of the last patient out of the trial. So who knows, by the end of April, sometime in May next year, we will have an answer to the question of how effective this therapy is. But what it is very potent dexamethasone in its formulation with cyclodextrin. There's an induction phase of 6 times a day drops for 6 weeks, followed by maintenance therapy of 3 times a day thereafter. So there was a stage 1 trial of 148 patients that was just a 12-week trial, 6 weeks of 6 times a day, 6 weeks of 3 times a day. And again, it was a 2-to-1 allocation of the fortified dex, this cyclodextrin-based dexamethasone, randomized 2-to-1 to vehicle. And dramatic effects were seen, improvement in visual acuity seen after 6 weeks, maintained in the subsequent 6 weeks when you drop the dose from the 6 times a day induction to the 3 times a day maintenance, and good maintenance of visual acuity then. 15-letter gainers were 25 to 27% in the treatment group over that first 6 weeks and maintained through the second 6 weeks. If you look at OCT thickness, dramatic reductions in OCT thickness noted within 2 weeks and maintained for the rest of the 10-week study period, i.e. the 12 weeks total. And it also, when they looked at subset analysis, and that's part of what I presented to the clinical trials at the summit, it didn't matter if the patients were phakic or pseudophakic, if they were previously treated or treatment naive, they all had significant improvements compared to vehicles. So again, it's an exciting approach, and you can only imagine the different ways we can use it. Let's assume it's approved with a broad label, but we could use it very early for early cases where we may not want to yet initiate intravitreal and anti-VEGF. Certainly, you could add OCSo1 as an adjunctive therapy to those getting anti-VEGF therapy. Those are the ones that I usually go switch to Dex implant, but you could consider now adjunctive therapy with topical OCSo1. Again, as a reminder, it's a steroid, so it's going to have some IOP, but the IOP seems to be modest and, again, relatively well managed. Nobody's needs surgery yet. We'll discover after a year of therapy on these 800 patients, we'll get a better sense of the safety. And again, cataract will be a potential scenario, but again, we'll learn more over time. But again, it will provide the potential for an additional, less invasive, again, topical therapy treatment option. With glaucoma drops, you worry about treatment because they don't notice the glaucoma, so there's hypocompliance. I'm worried that with this drop, if they're seeing a benefit, there may be hypercompliance. They may be squirting it in all day. So I've already warned the company that that they may need to be, well, the data will be interesting in the real world if it's approved, because I suspect if it's as effective as the early data seems to be, that patients may be overusing it, not underusing. But it's an exciting time. We'll see. Again, 2 phase 3 trials fully enrolled. We'll have the data sometime next spring.
Great. Thanks for a great overview, Barry. And I think you've been involved with steroids for a long time. We all know that they work. It's just that, obviously when you do an intravitreal injection, if you have a side effect, you cannot take it out. You have to ride the wave. Here you can stop the drop. And obviously needles, as Judy said, patients would like to have something that's non-invasive. The first question they ask is, do you have an eye drop or a pill, right? Before they agree to an injection. So Judy, Barry did a great job with the overview of the data. What do you think about the overall data that Barry shared on OCSo1, and where do you see it fit in your busy practice in Dallas with so many patients with DME?
Yes, that was a nice overview, and we know steroids work. There's a lot of inflammatory component to diabetic retinopathy and diabetic macular edema, besides the VEGF route that we've been working at for a number of years now. People want something that's non-invasive, so topical is great because, as you said, patients are asking for it. But others have tried, and there were no effects. It's hard to get it into the eye, the back part of the eye. But at least the 12-week data seem to show that this drug does get back, and there's some biologic effects. So those are all great. Unlike Barry, though, I don't think patients are going to be that compliant with 6 times per day for 6 weeks. I think it's a lot of drops for some period of time. So I wonder if they will be adherent to the 6 times per day for 6 weeks and then 3 times a day thereafter. I would love to see, the 1 year data, 52-week data, but it's encouraging that visual acuity improvement was seen, and almost as good as some of the anti-VEGF trials. Obviously, we can't compare trials, but even in anti-VEGF trials, 8 to 12 letters of gain, and 7.6 at 12 weeks is not bad. And some of the people gained 3 lines or more, about quarter, so 27% at week 12. And then the drawing effect was seen as early as second week. So I think these are, there's definitely something there. But as you said, Arshad, we want to also look at the side effects such as cataract and glaucoma. But, those things can be taken care of if this non-invasive topical therapy can help us treat those who are VEGF intolerant or non-responsive. Then I think it'll be great. I think in the long term we may have to add additional therapies, modality, mechanism of action to anti-VEGFs that we have. So this is wonderful.
No, I agree with you, Judy. I think it's exciting, but we have to see the full 1 year data set. And I think, 6 times a day of this potent steroid may be too much, but as clinical trials are designed for regulatory success. And I'm sure if it's approved and available, we can figure out maybe we don't need 6 times a day, right, Barry? It's just that we have to make sure that we are getting maximum efficacy initially. So that's why it was designed. But I'm hoping we can use it less often, but we'll see how the data pans out. But yeah, very exciting to have, a topical therapy. Obviously, as you mentioned, Judy, many have failed because a lot of eye drops go for new mechanism of action and they're topical. Here, at least you have a validated MOA, as you said, anti-inflammatory effect of steroids, and both you and Barry have been pioneers in getting steroids to the finish line for DME. And I think that at least here we don't have the risk of the MOA failing, right? It's more like topical is getting there. We have the data. It's just the long-term data we need to see, and if the studies hit the primary endpoint. So let's move on to systemic treatments. There have been a lot of oral treatments in our space that have failed, partly because they have new mechanism of action. And of course, the systemic, route to absorption in the eye, it's not easy. So recently we have many new pathways, the REF1 inhibition with APX3330. We have had plasma kallikrein inhibition. We have had some failures with intravitreal PCAL or plasma kallikrein inhibition, but there have been programs that have used that systemically and other pathways. So just kind of looking at multiple things that are out there, Barry, out of many programs that are ongoing and many have failed, as I said, what is exciting for you as a systemic route for the treatment of diabetic eye disease?
So it's an important topic. And again, it's rather ironic. One of the few label indications we have that essentially none of us use is monthly intravitreal anti-VEGF injections for patients with diabetic retinopathy. We simply don't use it. Certainly if the patient doesn't have DME. Of course, if they have DME, then we're happy to use those and they get the additional benefit of regression of their diabetic retinopathy. But there's that. It's a huge unmet need. We don't feel that the invasive approach with injections in a 20/20 eye is justified. We know that the recrudescence rate is high. Even if you go to quarterly injections, which I frequently do, and then I inevitably give up. It's not a route that patients or the doctors are really tolerating or using. So that forces us to consider other options. And again, the oral approach is an appealing one, but as you point out, it's got a lot of hurdles. It's, first of all, you got to get through the blood-eye barrier, the blood-retinal barrier. You have to be careful of systemic side effects because anything that gets through the blood-retinal barrier has to be in a pretty high dose nominally. But the potential for it is so appealing if there is something that can navigate all those hurdles, systemically tolerated and able to get into the eye, because it's a huge unmet need. It's why Judy in Dallas and me in Southern California, even in fancy Orange County, California, I still have huge number of Hispanic diabetic patients that are struggling because the treatment was initiated too late and they're struggling with that. So it's appealing. Various attempts have been made, as you pointed out. We like it to be as few times a day as possible. As Judy pointed out, 6 times a day of drops is a challenge. 6 times a day of pills or more, but again, once, twice a day. And again, there's some data that's coming out that looks appealing and promising. I like the kallikrein pathway. I like the other pathways as well. So we have an opportunity here to potentially expand our armamentarium in one of our biggest unmet needs, certainly for our diabetic patients, but in a societal sense. The number of patients, it's a huge epidemic. It's growing. If we could get in earlier with a non-invasive approach and prevent the formation of diabetic macular edema and diabetic retinopathy, that would be huge for society. One of the greatest things we could do.
Yeah, I couldn't agree more, Barry. That's a really good overview that obviously systemic has the potential to intervene early, but obviously we have to look at multiple challenges that are possible with these treatments. Judy, anything to add before we go into wrapping this up with talking more about both of your careers?
Yeah, the oral agents are really interesting because you can treat both eyes with one pill, 1 or 2 pills, right? So I think there's benefit in that, and maybe it will be economical too. Instead of 2 shots, you only pay for 1 pill that it treats both eyes. Besides the potential improvement in adherence. So if we can get some drug that's safe and effective. And I stress the safety because a lot of drugs previously have failed because of the safety profile. We knew who was getting the oral medication because of the side effects. So, with these ones, so far, they seem to be safer. I'm really intrigued about the APX3330, in the phase 2 Zeta-1 data. It showed that there was some favorable modification of the disease in preventing NPDR eyes from going on to PDR. So, as Barry said, instead of giving monthly injections, if a pill can do that, I think that's really interesting. And it also has a different MOA than VEGF. It's higher upstream and downregulates a lot of the transcriptional activity and that are pro-angiogenic and pro-inflammatory factors. So it may have a broad effect. So I'm really interested in this disease modifier through pill. You could sort of think of it as a statin of the retina. Statin slow down the cardiac disease, but maybe this is going to be the statin of the retina, where it slows down the retinal diabetic retinopathy progression, so that we don't end up with more severe disease that we have to operate on for traction retinal detachment and so forth. And the others, again, have a different mode of action, where it may be drawing the fluid in a non-invasive way with pills. The kallikrein system pathway is sort of interesting because that's totally different than VEGF pathway. So again, I think we have to be sort of like oncologists, use different mechanisms of action, layer on top of each other, start with maybe the disease modifiers, and then in early stage of DME, maybe a topical plus injections as needed. But because we got these other drugs on board, both orally or topically, that they don't have to have as many anti-VEGF injections, something like that going forward.
Well, that's a great overview. Yeah, a lot of exciting programs, a lot of shots on goal, but it's not easy to get systemic approved, as Barry said. So we'll see what happens. But yeah, we'll love to have topical. We'll love to have systemic treatment so that we can have better compliance and hopefully better outcomes by treating our patients early. Thank you both for great discussion. Last question for both of you now. This may take hours to talk about your career achievements. So we don't want to get there because, both of you have achieved so much in your career. Judy, you have done so many things, including being president of ASRS. Tell me, what is one achievement that you're very proud of?
I don't know. I mean, I didn't do any of these on my own. There was a village, or maybe in my case, army of people helping me. And I don't know a lot of things, but I know a lot of smart people who know a lot of things, and they've helped me around. So if one category I would pick would be leadership, organizational leadership, being president of American Society of Retina Specialists, president of Foundation of American Retina Specialists. I'll be the president of Macular Society in the coming year. I was board of trustee of American Academy of Ophthalmology, on the editorial board of JAMA Ophthalmology, and so forth. So what it has helped me is support other people, lead other people to do their best, and make policy changes or other changes within the organization that we can do more going forward. Because I tend to be a very strategic thinker, so I like to set the organization up for success by thinking about it now rather than on the spot. So that's I think being able to help others come on to the retina, and other women coming to women in retina, all those things I'm proud of. Thank you.
No, you have done a great job with the leadership, and that's only a small part of your achievements. You have done so many more things. So thank you for leading the way, Judy, and really inspiring all of us and a lot of women to go into retina. And now we have so many women in retina thanks to you and others. Now, Barry, how about yourself? Again, you have achieved a lot. You're chair of the department. You've been in many leadership roles. Any achievement that you want to highlight for our audience that you're very proud of?
Well, thanks. And it's always hard to talk about yourself. I think still I alluded to that first phase of my career where I was deep in the trenches of taking care of people with CNV retinitis from AIDS, after complication of AIDS. Their one plea to me, again, these were people of my same age with different sexual orientation. They would beg me, don't let me die blind. They all knew they were going to die. They were within a year of dying, and they were begging me not to die blind. And that was such a powerful, meaningful experience. So that was probably my most powerful clinical experience. But now for the last year being chair of the department and trying to grow it and build it. And we've doubled in size and we're doubling again and building a huge research unit and increasing our clinical unit. That's being a leader for my department has been very powerful. And along the way, one of the things that's given me great joy all along, I've had a large international retina fellowship program. So while we have an American retina fellowship program, I've really enjoyed in particular training people from all over the world. We usually have at any given time, typically 4 to 6 international retina fellows. They spend 2 years with us. So I've lost track of how many, over 100. They go back all over the world. Some stay in the United States, and that's been fun to establish these ties all over the world. That's been a very meaningful and enjoyable experience as well.
Very, very, very impressive, Barry, for what you have done, obviously training the next generation of U.S. retina specialists, but also globally. And of course, both of you have done this with very humble, friendly leadership too, right? I mean, sometimes people are successful like both of you are, world-renowned, and it's hard to work with them sometimes, but both of you remind me that you can do both. You can be successful, you can be kind, and you can be humble. So your legacies are great, Judy and Barry, and thank you so much for your time today for excellent discussion. And I want to also thank our audience for listening in. Thanks again, Judy and Barry. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Have a question for our experts? Send it to us at cme@vindicocme.com, and it may be featured in a future episode. Stay tuned for future episodes in the Retina Radar series to keep up with the latest insights and expert discussions.